Alaikum salam.
Good evening, everyone. Welcome to this next session as a part of the RWEsearch Annual Summit 2024. The next session is focused on the research length on Saudi Arabia health system. Today, we'll be exploring the pivotal role of data-driven decision-making that is being played out right now in Saudi Arabia's shift towards value-based healthcare. We have a panel of incredible experts to talk about this subject today with our audience. I'm honored to introduce our moderator, Rita Oji, with over 19 years of experience in pharma and healthcare and consulting in the Middle East and North Africa region. Rita currently serves as the Chief Operating Officer at Carexo. Her extensive expertise spans across various disease areas, including oncology, hematology, and immunology. She has led over 140 economic evaluations, including significant contributions to Saudi EQ 5D5L valuation and MCDA studies. Her insights in health economic modeling, HTA submissions, and outcomes research will be a key to driving the discussion today. Without further ado, I'll turn it over to Rita to lead us into this conversation. Thank you. Over to you, Rita.
Thank you, Doctor. And allow me, first of all, to thank your kind person for the honor and to thank our esteemed panelists for gracing me with the honor to moderate today this panel. I will start first by asking for a quick round of introduction, starting with our dear lady, esteemed Dr. Hajar, to introduce your kind person, please.
Thank you, Rita. Hello, everyone. My name is Hajar Mdehim. I'm a clinical pharmacist, served as the Director of Drug Policy and Regulation at the Ministry of Health, and a board member of Saudi Society of Clinical Pharmacy.
Thank you, Doctor. We're honored. Professor Aljedai, إذا بتسمح عمو المعروف.
Sure. Thank you, Rita, and thank you all for inviting me. My name is Ahmed Aljedai. I'm the Assistant Deputy Minister of Health for Therapeutic Affairs. I'm the founding president of the Saudi Society of Clinical Pharmacy and a full professor at Al Faisal University, College of Medicine and College of Pharmacy.
Honored. Dr. Faisal.
Yeah, thank you, Rita, and my honor, of course, to share the panel with such esteemed senior leaders in Saudi healthcare sector and distinguished guests. Hello, everyone. My name is Faisal Mahrous. I'm the country director for AstraZeneca in Saudi Arabia. Thank you.
Honored, Doctor. Allow me kindly, before we start our discussion, just to set the scene that for the upcoming 45 minutes, we will be navigating multiple topics, transformation of the healthcare system in Saudi Arabia under Vision 2030. Then we will be tackling and targeting the transformation from volume to value-based healthcare by moving into understanding the HTA adoption and implementation in the MOH and beyond. And inshallah, we will try to navigate as well the adoption of technology in terms of improving healthcare outcomes. However, I would like to ask our esteemed audience to make sure that we are maximizing on our time to kindly share your questions that I will be tackling toward the last 10 to 15 minutes of the session in the comment section to the right of your screen, if you kindly can grace us with your, let's say, inquiries. I will start first, without further ado, Professor Aljedai, if you allow me to address your esteemed person by asking you, in terms of providing us with an overview of the transformation in the healthcare delivery that is currently happening under the Vision 2030, specifically the newly established healthcare clusters in terms of this, let's say, new infrastructure, how it will be contributing to change, what will be the MOH role in this structure, will it be moving to a governance role, and if I may allow myself to ask you to expand on how will the organization of these ACOs will be looking like.
Okay, thank you, Rita. Thank you very much. Very important question. I have addressed this before, but let's get an update or a refresher on the follow-up that we are having currently on our health system transformation. So basically, we at the Ministry of Health are moving away from being direct provider of care to and a payer as well, to becoming more of regulators and policymakers, handing off the delivery of care and provision of care to the Saudi Health Holding Company, which is owned by the government, which owns the 20 different healthcare clusters. You refer to them as ACOs, or accountable care organizations. And this is the ultimate, goal, to have them as ACOs. Basically, these 20 healthcare clusters will provide care at all levels of care, including primary, secondary, and tertiary care, within a geographically located region with a catchment area between 1.5 to 3.5 million population, depending on the population of the catchment area. So, as I mentioned, they will be providing all kinds of healthcare, starting from primary, ending with tertiary care. At the same time, we recently created what we call the Center of National Health Insurance, which used to be called FAP, because it used to be a program. Now it's a center, and this was established by a royal decree that was released several months ago, and had two main aspects. One is the establishment of the health holding company, the establishment of the Center of National Health Insurance as the main payer for all government health care. At the same time, that particular decree indicated that Ministry of Health is the ultimate governor and the ultimate responsible body for putting all the regulations, controls, auditing, and as a supervising body on all healthcare, whether it's in the private or in the government sector. Now, having said that, this actually puts an emphasis on a dedicated health holding company for care provision. And Ministry of Health will continue to be the regulator and the visitor as well of the auditor as well. The government as well as the private sector, putting specific KPI goals and targets for the value for our patients. We are moving toward what we call value-based healthcare, which will put a lot of emphasis on the value of the care that we provide to our patients, and less on the volume or the number of treatments, visits, encounters. And this is very important to elevate the quality of care, as well as making sure that we have a healthcare system that is focused on providing the best and most cost-effective and rational healthcare to our patients.
Thank you so much, Prof. I believe you even tackled a question proactively that I wish to tackle, which really looks into the coordination between the role of the MOH as a regulator and the Center of National Health Insurance as a payer. And if you feel you wish to add anything, I'm more than, let's say, open. However, I would like to move to Dr. Faisal. If I may ask, Dr. Faisal, please. In terms of collaborative strategies, how can pharma companies support to adopt and align with the objectives of this transformation under the Vision 2030 in terms of working, collaborating with the healthcare providers, payers in the context of this transformational shift, whether in terms of delivery and under value-based healthcare, please?
Yeah, thank you. Thank you, Rita. Of course, now, as Prof mentioned, the transition now from volume to value-based care, it's required a robust collaboration between private and public sector, of course, G2B collaboration. In this evolving, let's say, landscape of value-based healthcare, pharmaceutical companies' strategies, they should be adopted on the collaborative, let's say, a strategy that should align their objectives with those of healthcare providers and payers and the government as well. Initially, the approach from a pharmaceutical company or the industry, it's involved establishing a partnership that focus on shared outcomes. This can be achieved through outcome-based agreements where the reimbursement is tied to the effectiveness of the medications. Such agreements, it will incentivize the pharmaceutical companies, of course, to invest in real-world evidence generations, thereby enhancing the credibility of their products in front of the healthcare sectors and the policy makers. Moreover, engaging the healthcare providers in the drug development process will, of course, as a strategy, will foster a greater understanding of the clinical needs of the value for the treatment in the healthcare ecosystem or the pathways. By incorporating, providing insights, pharmaceutical companies can, of course, optimize their offering to enhance patient outcomes and reinforce the principle of value-based care. In a summary, let's say the strategic partnership based on outcome agreement and educational collaborations initiatives between pharmaceutical companies and healthcare ecosystem can effectively align their objectives with those of the healthcare providers and payers, which of course will foster the ecosystem that focus on the value rather than volumes, and of course it will improve the patient care and outcomes.
Thank you, Doctor. And unfortunately, I believe we lost the connection with Prof. Aljedai. However, I will allow myself to jump between the questions. I had the honor of working very closely with Dr. Hajar, and your esteemed person, as you kindly know. Saudi MOH has been a beacon in leading the transformation from volume to value-based healthcare. Professor Aljedai is back to us. So, Prof, I hope all is well in terms of connection at your kind. And Prof, we had the honor of really observing the amazing transformational shift from volume to value-based healthcare, not just across the region led by the Saudi MOH, but also, allow me to say, globally. If I may ask your esteemed person, across all the very well positioned pillars of value-based healthcare, if you can share with us a brief of the key initiatives that the MOH has led since 2018 to adopt and even drive this transformational shift into VBHC, please.
Okay, thank you very much, Rita. Basically, we started actually in 2017 adopting the concept of value-based care, and which is, by the way, not new. It's been, described by Prof. Porter and Prof. Tisberg in 2006, and it's been adopted by different healthcare systems, governments, health technology assessment bodies in different parts of the world. So what we did actually is revamped the way we assess and evaluate health technologies, starting from medications, as we have a central pharmacy and therapeutics committee in the Ministry of Health, which is considered, the largest healthcare provider by far, accounting for 80% of the government health sector and around 60 to 65% of the total healthcare provided in Saudi Arabia. And we also provide care to the largest number of population, around 23 to 24 million population in a very large geographical area, which puts a lot of challenges in terms of not only delivery, but also governance and regulation. So what we aimed, at is to develop standardized method of evaluating these health technologies by conducting a systematic process of evaluating the safety, clinical efficacy, as well as the value for such new agents. And as you all know, the medications that we have these days are totally different than the medications we used to have 20 years ago. Now we're talking about more targeted therapy, more of biologicals, gene and cell therapy, RNA therapies, mRNA platforms, and all of these, which come with a hefty price that needs to be evaluated carefully to make sure that we actually pay for something that works and for something that would impact our overall healthcare system. We initiated our healthcare transformation plan according to the Vision 2030 pillar. And one of the main pillars was Vibrant Society in Vision 2030, which focused on improving the overall health of the society, not necessarily the healthcare, but the overall health of our society, starting from creating a healthy subject who can remain as healthy as possible and not seek medical or not needing medical care or health care as much as possible. And this involves multiple targets, multiple KPIs, improving the overall awareness, public awareness, education, counseling of subjects in order to adopt more healthy lifestyle, as well as avoid risky behaviors that might lead to worse health outcomes, starting from quitting smoking, reducing weight, exercise, and adopting more of a healthy lifestyle concept. In addition to this, we also had a very specific KPI within our Vision 2030 Vibrant Society pillar that focused on achieving an average life expectancy by 2030 that is equal to 80 years as an average between men and women. When we started our Vision 2030 in April 2016, we had an average life expectancy between men and women of about 74.8. We are in the mid Vision 2030, and our average life expectancy currently is hovering around 78 years, and we're aiming to achieve our 80 years target by 2030, inshallah. So part of this is part of the concept of value-based healthcare that we adopted is the ability to evaluate these new health technologies that come with heavy price tag on them to make sure that these are the ones that we really need to implement and adopt in our healthcare system. So we developed a standardized systematic process for reviewing all of these new medications, coupling this with clinical, societal, economic evaluations to make sure that we are actually getting the best out of the newly approved medications everywhere. Now, one of the things that we worked on is we identified that we did not have specific requirements for conducting appropriate health economics evaluations. And thanks to you and many others who actually worked with us to develop the first ever willingness to pay or cost effectiveness threshold in Saudi Arabia and in the region, which we published last year. And this year, beginning of 2024, we also published the first ever valuation, the utility valuation set for Saudi Arabia for adults, the EQ based on EQ5D5L from EuroQL. Also, we developed what we call the multi-criteria decision analysis, or MCDA, for evaluating medication, orphan drugs for rare diseases that usually affect a small percentage of the population, but they usually are much more expensive than medications that are used for chronic diseases. So with this, we are embarking on other initiatives, including the AQ5D3L for adolescents, hopefully, and then also we're trying to build other cost effectiveness threshold for different disease states, including end of life medications, as well as other tough to treat or difficult to treat diseases and other rare diseases. One of the things that we have worked on is building capabilities and improving our capacity, learning from what's out there from other health technology assessment bodies in order to build our first health technology assessment body and exercise HTA as a concept and as a process rather than only a center that is called HTA Center without having clear involvement in decision making for our patients. We have started lots of projects involving development of registries for multiple disease states, as well as development of value-based agreements that hopefully, if we have time, we can talk about them, linking outcomes to reimbursement.
That will be a topic that I will be tackling in a few. And before going to Dr. Hajar, I want to ask Dr. Faisal, if he allows me, from the private sector perspective, what are the key challenges that your esteemed person are facing? And if I may maximize or expand on the question, if you can kindly share with us, how are you gearing up really to collaborate with the public sector in terms of facing these challenges and even driving innovation in Saudi Arabia?
Thank you, Rita, for this big question. I think the challenge exists everywhere, but it's different, of course, across the pharmaceutical industry from company to another, according the readiness of the company to adapt their not only their business model or structure, but even to adapt their culture and the mindset within the organization to the changes within the healthcare ecosystem, especially this move or shift toward the value-based care. So let me start first by the key challenges which is facing the pharmaceutical industry for the shift from volume to value-based healthcare. The significant changes that first the shift required, as I have mentioned, a fundamental change in the business model and the culture model, wherein the companies must focus on the patient outcome rather than only focusing on promoting and selling their products. This change required, let's say, more investment in R&D to create drugs that not only demonstrate the efficacy, but also to enhance the overall patient's quality of life and improve the patient outcomes. Additionally, the move toward the value-based care require from pharmaceutical company to foster stronger collaboration among all stakeholders, as I have mentioned, from private to public sector, including, of course, the healthcare providers, payers, and even the patients. So pharmaceutical companies must engage in an innovative ways and foster the partnership agenda to design and implement, let's say, for example, the risk-sharing agreement, which is potentially linking the drug prices to the outcomes. Finally, regarding the challenges, the business model and culture shift within the organization now has become more profound, as employees within the organization, starting from the senior leaders, must embrace a patient-centric approaches, focusing on the health outcomes rather than, as I have mentioned, focusing on promoting or selling only their pharmaceutical product. The second part of the question, how the pharmaceutical companies are gearing up now for this shift. The healthcare ecosystem across the globe, it's undergoing a transformation. And here specifically in Saudi, it's undergoing a big transformation, which is one of the most important themes toward achieving the Vision 2030, which is, of course, improving the access quality to healthcare services, enhance the e-health technology and innovative digital solution. This is the key pillars for this achieving this transformation. And this shift or this transformation also, it's, let's say, characterized by adoption to the value-based care into the decision-making process. Pharmaceutical companies are now focusing on developing medications that demonstrate clear clinical benefits and positive health outcomes. This shift required investing more, as I have mentioned, in clinical trials within the kingdom to work to localize the clinical trial for the new innovative medications in the kingdom, not only in the kingdom, but even to be a hub for the Middle East and Africa. Also, not only to assess the efficacy of their medications, as I have mentioned, it should be also assess the long-term value and impact of the treatment on the patient's quality of life. By doing that, pharmaceutical companies will seek to build a compelling value proposition for their pharmaceutical product, with enhancing their credibility with payer and healthcare providers across government and the private sector as well. Additionally, of course, the partnership between pharmaceutical companies, healthcare providers, payers has become more prevalent. And such collaboration, Rita, it will facilitate establishment of the risk share agreement, where the payment for the drug, it will be contingent upon the performance in the real world settings. This approach not only mitigate the financial risk for the stakeholders, but again, it will reinforce the commitment and the credibility for the pharmaceutical companies that they are working to improve patients' outcomes. Long story short, as the industry or pharma industry embrace the value-based healthcare, pharmaceutical company are obligated or compelled to innovate not only in their product, but also in their business model, culture model, mindset model, and they should fostering the healthcare ecosystem centered on efficacy, patient centricity, and sustainability.
Thank you, Doctor. I hope that Professor Aljedai can join us in a few again, because he wished to discuss really the overall scope of value-based healthcare in terms of performance-based agreement. But I will go to Dr. Hajar. Dr. Hajar, I had the honor of engaging my Hadartik across multiple HTA key initiatives. So I will start by asking Hadartik if you can share with us, as we all know that the MOH have a stringent guidance on the process of health technology assessment. If I can start by asking you to share an overview of the process and how the MOH is the first HTA authority that have led clear defined processes for health economic evaluation, and how is it done by linking it to negotiation of managed entry agreement, and ultimately in terms مثل ما قال Dr. Faisal, registries generation of real-world evidence to support patient outcomes.
Thank you, Rita. So basically, what we have been doing in the last 6 years, whenever we are going to introduce a new intervention to the formulary, we are not looking only to this particular medication, but the entire class or the entire indication, or slash disease. So we need to review the entire class of this, let's say, intervention. We look at the safety, efficacy, and definitely we built the budget impact model for us to see how is this going to reflect into our budget, and whether by inflating it, of course, with the new upcoming interventions that are coming with a really high tag price. And once we are doing this, because we don't have that data really sitting in one place, we are very segregated healthcare, different healthcare systems. So we usually, let's say, rely on our key opinion leaders on their particular disease and asking multiple questions from the prevalence, incidence of the disease, total number of disease, let's say the diagnosis of these disease states, and so on. And we build the model based on a certain clinical data, and having this flavor of our KOLs into this model. But thank God, now we really have state-of-art registries that really reflects the total number of patients that we are carrying, the segregation of these patients, the tiering of these patients, severity, what is their risk factors, everything is being now is very clear if we are going to reintroduce or evaluate a new intervention in these multiple diseases. Now, currently we are, and you know that we are carrying more than, I think, 14 or 16 registry. 3 of them are national ones, SMA being one, retinal dystrophy being the second, and multiple sclerosis being the third. And now the upcoming expansion, let's say, for sickle cell as well, to be on gathering a national level of information. So all of this really guide us in let's say, a decision making that really reflects our country, our patients, and it have a selection of the criteria or certain criteria, eligibility, let's say, criteria that we know that those patients will really benefit from this intervention. And here comes the second layer of having multiple negotiations with pharma industry when it comes to their value proposition. So we don't go directly to the pricing, because the pricing is being covered by NIPCO, but we negotiate with them in matter of the definition of failures and the percentage of the rebates, the duration, and we always made sure that this criteria is being, let's say, logic when it comes to evaluation, the evaluation of this intervention in a period of, let's say, 1 year, 2 year, whatever the contract is, and we usually extend to these, let's say, agreements. Another part of it is releasing these data. So now we are obligated to share the insights of the country when it comes to certain disease area that would help us really to reflect on the burden of disease in the country. Certain diseases we do not have really a reflection on the burden of the disease, because we don't know what is the impact on the country. And this would be a base, or let's say a fundamental base for us to work through, let's say, a structured evaluation when it comes to Saudi Arabia. Over.
Thank you, Doctor. Allow me just to أعقب على point حضرتك you just shared. In terms of the release of the data, حضرتك you mean that the publication of the registry's outcome?
Exactly. Yes.
This will be great news. So we are anticipating this in the coming few months, 1 year, because we, as you kindly have said, there are multiple registries that are being implemented.
True. We are working on
really one more
certain ones that are going to be published very soon, inshallah.
Alf Mabruk. Doctor, if I may ask, out of curiosity, we have been hearing since some time that and Prof. Jeddah just mentioned before we lost him, unfortunately, that there will be an HTA office, an entity that will be leading all these healthcare evaluations. How, in terms of timelines, in terms of structure, who will be leading this? Do you have any visibility that you can share with us?
So yeah, so basically it is in the Ministry of Health, and it's incubated there. We are actually running this in matter of this evaluation. So the activity, as you have known and witnessed, been for the last 4 years that we are doing these certain HTA activities, from creating the cost effectiveness threshold, from getting the utility sets for the first time in the kingdom, and all these activities being already published and available. So these activities is being let's say available. The HTA will be under the Ministry of Health, and this is all what I know.
Merci, Doctor. Although I would have wanted to tackle some questions with Prof. Jeddah, but if I move to last section of our discussion today, by really looking into the use of technology in terms of accelerating value-based healthcare. So, Doctor, I had the honor of talking to you yesterday, and I want to ask you, in terms of integrating patient support programs, remote monitoring, are there any initiatives حضرتكم you are leading in terms of adopting these?
Exactly. We are all our registries is being linked with a patient support program in matter of to make sure that the patient is adherent, compliant, and we follow the patient with different monitoring scores that we require in order to make sure that the value proposition of the medication is being met. This is from the clinical, let's say, arm. The other arm would, if any of our patient require some assistance, questions, all of this would be directed to the management of these registries that it's linked with patient support programs, and it is mandatory now to have these patient support linked to any of these registries.
This is very important. Are you thinking, doctor, to include these, let's say, initiatives in the actual manuscript for the registry's data that will be published?
Yes, we would.
My last question, we still have 5 minutes before jumping to the audience questions. أحملك المسؤولية دكتور راجع Prof مش معنا. Can you kindly, doctor, from technology and clinical research perspective, if you can share with us what will be the role of Nafis in the future, inshallah, and how the MOH will be collaborating with Nafis to drive technologies or potential clinical research, or at this stage, the clarity is not yet there?
So Nafis is the actual hub of linking the different resources or different, let's say, interventions that it is linked for the entire country. So it would be easy to link different health entities with the same platform. So it will be taking this information from a unified platform would be much easier, as you know that all entities or all healthcare entities will be under one regulator, and this would really ease the utilization of these data. So Nafis would really help in having an overview on the utilization of different interventions.
Thank you, Doctora. I'm very glad to have the Prof back with us. لأنه Prof, I would like to hear from you. حضرتك, you also proactively shared that you want to grace us with the perspective of how the MOH is leading the integration of value-based agreement, potential discussion on alternative payment models. What is the future of these initiatives, knowing that the MOH has been always driving really this transformational shift in terms of adopting innovative approach? I hope you can hear me.
Thank you, Rita, and I apologize for the connectivity issues. That's why I turned off my camera so I can actually hear you well and you can hear me well. Yes, I would, mention something very important. I think we're building capabilities as we move forward toward the Vision 2030, achieving the Vision 2030 goals within health transformation program. We have established what we call the HSTP, or Health Sector Transformation Program, which is supposed to, play the coordinator program for all healthcare sectors, including the private and different government sectors. Aligning, the vision, aligning the goals, as well as, implementing national programs that would address certain models of care, whether starting from, chronic diseases, acute care, children and women health, and preventing communicable and non-communicable diseases, and also healthy lifestyle and others. So having said that, one of the things that we have great experience now and is the value-based propositions that we have in different capacities, not only the value-based agreements or value-based programs that we have initiated, and Dr. Hajar, alluded to, also including the different registries for disease and drugs. We are actually aiming at developing rare disease center of excellence within Ministry of Health. We're discussing multiple initiatives to improve the overall national health in Saudi Arabia, capitalizing on the different strengths available in the private and the public sector. For the first time, we implemented what we call the insurance drug formulary, in the private sector, which aims to standardizing the care and providing equitable and fair healthcare to all insured individuals. Nafis, and I think you talked about also Nafis, and Dr. Hajar also commented, Nafis is going to be, the back end of all of our electronic health systems, or electronic health records, where we can actually gather data from all sectors, whether private or public, know more about the prevalence of diseases, know more about the behavior of practitioners, assess the quality of care provided to our patients, and value-based programs is just one of the initiatives that we worked on, and I think we are leading the region when it comes to implementing these value-based programs, linking them to outcome and the performance of these medications. We're actually moving toward non-medications as we speak now. We're evaluating multiple health technologies, including but not limited to smart pumps, insulin pumps, different medical supplies attached to patients, and making sure that we adopt something that would benefit the individual, but also impact the overall health of our society.
Prof, if before I move to switching to the current audience questions, I have a bit of a curiosity to ask your esteemed person. What about the health technology assessment of potentially medical devices, screening programs? Are these being considered in the future as potential initiatives to be led by your esteemed person as in terms of evaluations?
Yes, absolutely. So we started with the new generation insulin pumps that are implanted in our type 1 diabetics, and we are undergoing the they're undergoing the evaluation from 360 degrees, including societal, economic, social, quality of life, as well as improving the control of those patients and trying to prevent the devastating complications of diabetes in such patients. But we are considering also some of the medical devices and medical supplies. We haven't moved into screening programs. However, we conducted one activity of premarital screening of certain genetic diseases to prevent these genetic diseases, which resulted in a recommendation to health leaders to implement 5 different premarital tests for genetic diseases, including SMA, urea cycle syndromes, and other MPS, maple syrup syndrome, and also other genetic diseases of high burden in our society.
Thank you, Prof. Before moving to the audience, I would just want to tackle Hadartak a question in terms of clinical research. What are the key initiatives for the coming, at least short term, 2 to 3 years, by the MOH to lead real-world evidence generation beyond registries in terms of clinical trials in the MOH as a sector or even on a national level?
Okay, so I think the registries that we developed, we have currently more than 17, 18 different registries, are very important inputs for our real-world evidence generation. We have actually started publishing some of the insights that we have gathered over the last 4 years, but also clinical trials is extremely important for us, including rare diseases, and that's why we implemented the first CTU or clinical trial unit in Medical City in the first health cluster in Riyadh. We're moving to Taif and Qasim, where we will be hopefully working together with these regions to implement the clinical trial units there. And we hope that this is going to help attract more clinical trials, global clinical trials, to become part of the multi-center, phase 2 or 3 trials, in addition to conducting our own clinical trials that might not be sponsored by the pharma industry.
Because I'm a bit greedy, Professor, allow me to ask a bit of a question. In terms of Center of Excellence, what are the key pillars of the Center of Excellence for Rare Diseases Management?
Okay, this is a great question. So basically, we would like to, we have lots of rare diseases here in Saudi Arabia. Consanguinity is one of the major issues we have. And this results in lots and lots of rare diseases. And as you all know, rare diseases are rare individually, but combined, they're actually not rare. We have more than 7,000 different rare diseases, and most of them, they don't have available treatment or approved treatments other than supportive care. Our first and most important aspect is prevention, public awareness, family counseling, genetic counseling, in addition to premarital screening. But also we work on developing center of excellence when it comes to running clinical trials and also treatment of innovative approach. I'm sure you've read this week the first gene editing therapy in the world administered was in Saudi Arabia for treatment of beta thalassemia and sickle cell disease outside clinical trials. So we would like to position Saudi Arabia globally as one of the countries that are leading when it comes to rare diseases.
Building on what حضرتك just shared, I will start with the audience question for the last 5 minutes. A question لحضرتك Prof ولدكتورة هاجر. In terms of these value-based agreement from Dr. Goraf, which indications are a priority? Are there certain prioritized indications that you are addressing in terms of health technology assessment, value-based healthcare? Is in oncology one of these indications as priority, considering that it comes with a high cost of medication?
Yeah, absolutely. Oncology definitely is one of them. We have multiple actually disease states depending on the disease burden, disease prevalence, and the availability of a cure versus treatment that would decrease the progression of the disease and prevent, consequences or complications. Oncology is one of them, hematology, neurology, immunology, and we have also neurology. We are contemplating moving forward with other disease states, such as chronic disease states. Diabetes is one of them. We're currently evaluating value-based performance or outcome-based agreements for gene therapy or cell therapy, for treatment of type 1 diabetes or prevention of type 1 diabetes in patients who are considered pre-diabetics.
Thank you, Prof. Out of respect to Dr. Anish, I know that Dr. Hajar shared that there is more than 16, 17 registries. However, allow me to share the question for your kind guidance, Doctor. Is there an infrastructure for data tracking for clinical biomarkers, not just registries for medication, that is currently available or, let's say, deployed across the MOH infrastructure? Electronic medical records in terms of tracking of any type of, let's say, screening, testing, any type of, let's say, health records that is currently available at the MOH, any plan to really deploy
For me, Rita?
records?
Okay, sorry. I thought you were asking Dr. Hajar. Okay, so yes, absolutely. We have, in certain diseases, we do have very good data. that will help us, generate, evidence that would aid in making decisions towards management of certain diseases. One of the things is blood disorders registry, which is considered the largest registry in the world. Having more than 75,000 patients in that registry. We also capitalize on our electronic health records by installing or implementing the first ever unified electronic health records in the primary care called RWEsearch, which will help gather all the data for all chronic diseases, as well as the overall health status of patients who are being followed in primary healthcare centers. In addition, we are hopeful that Nafis as a backend will help us in understanding different, aspects of management of diseases. The Saudi Center of Health Insurance is actually developing a structured data from all health insurance companies with certain requirements so that it can be helpful in supporting the decision of health coverage, as well as for all patients, and improving the essential benefit package of health policies.
One last question, and honestly, personally, it means to me a lot. If you can, Prof, share with us the experience of the Saudi MOH being the first entity globally to assess all 3 new genetic therapies, because this is something that is very important to share and highlight. Sure. And even these will be presented. It was presented one in last ISPO this year as well. Mabruk. Dr. Hajar will be also presenting the second. So if you kindly can share your experience on how the Saudi MOH led this, because this is something that no one, I believe, globally did it. So please, for both of you, before closing.
Yes, we were actually pioneers in evaluation and assessment of multiple new innovative medications for rare diseases, such as, and I think I'm getting a call here. I'm sorry for this. Okay, sorry, I just got a call. So we conducted actually health technology assessment, appraisal, and evaluation, health economic evaluation for the 3 agents used for management of SMA, which is a rare disease, neuromuscular disease, addressing the gene therapy, RNA therapy, and the oral therapy for SMA. We also conducted an evaluation for the, or we are currently conducting an evaluation for the gene editing therapy for sickle cell and beta thalassemia. And we were actually the first country to design and implement performance-based or outcome-based agreement for the 3 agents in SMA, which used to be as a reference to other countries to implement similar outcome-based agreements.
Thank you, Prof. And this is something that I believe is worth closing on in terms of achievement. And a very big congratulations for all 3 posters being approved by ISPOR Europe. Allow me, before I close, to ask your esteemed person if you felt that I have missed any question that you would like me to tackle.
Thank you, Rita.
You would like. Merci. Allow me to thank your esteemed person for gracing us with your presence, and always it is an honor to be among you. Merci كتير على الشرف. I wish you a beautiful, blessed rest of the evening, and really stay safe. Merci كتير.
Thank you, Rita. Thank you, Prof. Thank you, Dr. Hajar. Thank you.
Thank you, Dr. Faisal.